CME Outfitters, I would like to welcome and thank you for joining us for today's educational activity entitled Finding Your Footing in the Shifting Landscape of Multiple Sclerosis. Today's activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. Today's CME continuing education activity is also eligible for ABIM MOC points. Once you complete today's program, be sure to provide your ABIM ID and birth date in the evaluation. CME Outfitters will submit your MOC points. You can also claim this activity as CME for MIPS improvement activity. As I mentioned, I'm Michael Racky, currently Neurology Medical Director for Quest Diagnostics and formerly the Chairman of Neurology at the Ohio State University Medical Center in Columbus, Ohio. Let me introduce our faculty joining me today. I'd like to welcome my colleague, Ann Cross, who is a professor of neurology and the Manny and Rosalind Rosenthal and John L. Trotter Multiple Sclerosis Center Chair in Neuroimmunology at Washington University School of Medicine in St. Louis, Missouri. Welcome, Ann.
Thanks, Mike. Good evening.
I would like to also introduce my colleague, Mitzi Williams, who is a neurologist and multiple sclerosis specialist and the founder and CEO of Joy Life Wellness Group Multiple Sclerosis Center in Atlanta, Georgia. Welcome, Mitzi.
Thanks so much, Mike. It's my pleasure to be here this evening.
Let me first review our learning objectives. Our first objective is to identify the immunologic mechanisms that contribute to multiple sclerosis. Our second learning objective is to assess clinical data supporting the efficacy and safety of novel and emergent immune-directed therapies for MS. And our final learning objective is to integrate biomarkers and imaging techniques to assess disease activity and progression in patients with MS. Let me start our discussion today by setting the stage. When we think of multiple sclerosis, we think of the clinical events, the exacerbations. However, much of the disease is clinically silent. We don't fully understand the pathogenesis of MS, but we do think that MS could be a single disease or a number of different pathologies that end up in the same expression. Triggers of inflammation include infection, and we think that that may be a mechanism of how the immune system gets activated to initiate MS. Such activity could include activating T cells, which are cross-reactive, a process known as molecular mimicry. I've partnered with CME Outfitters to develop a series of 3D animated models showing the immune mechanisms of MS pathology over the course of disease. You can find this interactive tool on the Multiple Sclerosis Hub on the CME Outfitters website, and I encourage you to explore this animation on your own. Now, let's look at the gross anatomy of MS lesions. Here we see the typical juxtacortical and periventricular lesions that are typical in the cerebral hemispheres in a patient with MS. You can see how more lesions appear over time. Glial scars form in chronic inactive lesions. Brain atrophy begins in the earliest stages of relapsing MS and becomes much more apparent in progressive disease. Here we see a slide that shows 3 patients and the disease activity that occurred on MRI. If you look at the middle panel, you can see that many gadolinium-enhancing lesions occurred, but there was only an exacerbation occurring at month 20. This is, as I mentioned earlier, that the disease is often much more active in the brain than what we can appreciate clinically. However, if you look at the panel on the right, you can see a patient who also has similar activity on MRI, but has much more clinical activity with a number of arrowheads demonstrating clinical exacerbations. Let's return to our 3D model for a close-up look at how lesions form and evolve over time. Here's a close-up view of one of the juxtacortical lesions we just saw develop. Lesions may fade on T1 weighted imaging when patients are in remission and return during relapses. The color red shown here indicates active inflammation. After the inflammation subsides, chronic lesions can appear hollowed out or marked by bumpy scar tissue. When we see those lesions, as clinicians, we typically appreciate them on MRI. However, recently, we've also recognized that cortical lesions occur in multiple sclerosis. Here on the next slide, you can see imaging of cortical lesions on high field MRI. Typically, one can't see these lesions on lower field MRI. However, the steps in terms of inflammation and pathogenesis appear to be the same. We're going to see this slide several times to try to illustrate points that occur in terms of MS inflammation. Now, let's return to our 3D model to look at how lymphocyte activation occurs in the early stages of MS. Here you can see motor neurons whose axons are enclosed by myelin sheaths that are maintained by oligodendrocytes. You can also see resident microglia in the central nervous system and a post-capillary venule whose walls represent the blood-brain barrier. Guarding this capillary is a perivascular microglial cell. The blue dots on this cell represent myelin antigens being presented by MHC molecules. So this antigen-presenting cell is poised to interact with myelin-specific T lymphocytes that might come in contact with it. Here we see a T cell that passes through an endothelial cell in the capillary wall that will immediately encounter a perivascular microglial cell. This is an antigen-presenting cell that interacts with the T cell, causing it to release cytokines. As a result, the endothelium upregulates adhesion molecules to allow inflammatory cell infiltration. So after we've seen lymphocyte activation, the next thing we need to think about is what influences T cell differentiation. As you can see in this slide, cytokines such as interferon gamma and IL-12 can influence differentiation to the Th1 phenotype, which we think is the predominant phenotype of T cell in multiple sclerosis. There are a number of factors that can influence differentiation, however. I've also indicated here microRNA, which are overexpressed in multiple sclerosis, which appear to downregulate differentiation down the normal Th2 regulatory pathway and influence differentiation down the Th1 pathway. In addition, we need to also think about how the cytokines can affect the inner workings of the cell and the transcriptional regulation of T cell differentiation. Currently, most of our therapeutics affect the cells and the cellular immunology of MS. However, some treatments under development affect the transcriptional regulation, such as dimethyl fumarate. Let's return to our 3D model to look at T cell differentiation. Activated microglia secrete cytokines such as interleukin 12 and interleukin 23. A CD4 positive T cell differentiates into a T helper 1 or Th1 cell, which subsequently proliferates, which subsequently activates a B cell. Here we see that immunopathogenesis slide again. Once the T cell crosses the blood-brain barrier, it once again can interact with the microglial cell. and then subsequently secrete molecules that can affect demyelination. Let's return to our 3D model to look at how inflammation leads to axonal demyelination. B cells produce antibodies that bind to an antigen on the surface of the myelin sheath. Macrophages express an Fc receptor that allows them to bind to the antibodies coating the surface of the myelin. They strip off the myelin, exposing the bare axon underneath. Nerve impulses cannot be transmitted through the demyelinated segment of the axon until the axon upregulates sodium channels along the axon to allow transmission to resume, albeit slower than through fully myelinated axons. Demyelination of axons gives rise to clinical signs and symptoms of multiple sclerosis. Here we can again see our immunopathogenesis slide. Here we can also see the macrophage in the top of the slide, recognizing that antibody as we saw before. Antibody and complement, nitrogen-oxygen species, and tumor necrosis factor are other mechanisms that also participate in the demyelination process. Let's return to our 3D model to look at what happens in the MS lesion to bring about remission. Now let's look at how this inflammation subsides, leading to clinical remission. Here you see activated microglia, macrophages, and astrocytes, and you see lymphocytes secreting pro-inflammatory cytokines, all contributing to inflammation. CD8 positive T regulatory cells can oppose this inflammation, reducing the number of T cells and causing a shift toward the production of anti-inflammatory cytokines and growth factors. Remyelination can occur, restoring normal nerve conduction speeds, as you see in one of the two demyelinated axons depicted here. There are a number of strategies where people have tried to enhance T regulatory cells in multiple sclerosis. One of the things that may be working against this is the fact that MS patients appear to have microRNAs which target TGF-beta signaling, impairing the MS patient to make inducible Tregs. Let's return to our 3D model to look at what happens in relapses and how immune-directed therapies can interrupt the pathological events that lead to relapses. Relapses can occur following the same sequence of events we saw earlier with the emergence of MS. Here you see that a relapse causes additional demyelination. Exposed axons are vulnerable to being transected by cytotoxic CD8 positive T cells. This causes permanent disability because axons cannot regrow and reconnect with their targets. Let's look again at our immunopathogenesis slide and how our treatments may affect MS pathogenesis. If you look at the center, there's a T cell expressing VLA4 and LFA1. These adhesion molecules interact with VCAM1 and ICAM1 on the endothelium. Administration of natalizumab binds to VLA4 and inhibits the ability of the T cell to interact with the adhesion molecules. Similarly, matrix metalloproteases 2 and 9 are required for the cell to cross the blood-brain barrier. One of the mechanisms of beta interferon is to interfere with the synthesis of these molecules. Similarly, T regulatory cells, including HLA-E restricted CD8 cells, are upregulated by glutarimer acetate. Finally, other monoclonal antibodies, such as alemtuzumab, which targets CD52, and the anti-CD20 directed treatments, ocrelizumab and ofatumumab, target CD20 expression on B cells and on a small population of T cells. Many of you are probably familiar with this slide. As you can see with the yellow bars, this represents instances of inflammation. However, over time, the inflammation appears to be reduced as the patient enters secondary progressive MS. However, we could see that this is the time when atrophy and axonal loss is most prominent. Let's return to our 3D model to look at what happens in progressive MS. Here you see an ectopic germinal center, which is a lymphoid follicle-like structure that forms in the cerebral meninges of patients with progressive MS, but typically is not seen in early relapsing remitting MS. In progressive MS, Th1 cells and microglia again contribute to neuroinflammation, releasing both pro-inflammatory cytokines and also reactive oxygen and nitrogen species that cause oxidative damage to cells of the CNS. Let's look at how inflammation affects nerve impulse conduction in MS. The neuron on the left is healthy, with normal fast nerve conduction. The middle neuron has a partially demyelinated axon, and you see that nerve impulses slow down as they pass through the unmyelinated section of the axon. The neuron on the right has been transected, cutting off signaling. The distal end of the axon that has been severed from its cell body dies. Chronic inflammation can cause even untransected neurons to sustain sufficient damage that they too may also die. Neuronal cell death contributes to brain atrophy and permanent disability in patients with progressive MS. I know those were a lot of animations, but I think they really help us understand the immunological mechanisms of MS, and I want to encourage you to use these animations for teaching. You can find these animations on the MS Hub on the CME Outfitters website. Let's turn now to our second learning objective, which is to assess clinical data supporting the efficacy and safety of novel and emergent immune-directed therapies for MS. Mitzi, can you get us started with a patient case illustrating a typical presentation and how you approach initial treatment decisions?
Absolutely, it's my pleasure. So let's start with our first case. This is Laura, who's a 26-year-old woman who woke up with symptoms of visual loss a few weeks before presentation. She felt like she had a film over her eye, which is a typical description when people are dealing with optic neuritis, and she had a diagnosis of optic neuritis that was confirmed by an ophthalmologist. She was treated with several days of IV steroids, and after that time, she had about 80% improvement in her symptoms. Of note, she's also married with 2 small children and looking to expand her family in the future. So that's certainly a consideration. Also, upon further history taking, she had an episode about 5 months before presentation where she had foot drop and weakness in her leg. And that also improved, but did not completely resolve. She did not have any imaging at that time, so we're not sure what her imaging looked like at that point. On exam, she had about 20/20 vision in her left eye, and she also had 20/40 in the right eye, as well as other symptoms of hyperreflexia, weakness in the right lower extremity, and foot drop. Otherwise, her exam was unremarkable. In terms of testing, she had imaging that showed greater than 10 supratentorial lesions, with several of them enhancing. And she also had multifocal disease in the cervical spine without enhancement. She had a lumbar puncture that showed greater than 5 oligoclonal bands, and she also had negative aquaporin 4 antibodies. So let's get right to it. How would we treat this patient, or how would you treat this patient? Why don't we go and talk a little bit more about what makes this patient potentially more high risk, and how we look at prognostic factors. So when we look at predictors of poor prognosis with MS, there are a couple of different categories that we can look at. So certainly there are demographic things, and I'm not going to read everything on this slide to you. Certainly you'll be able to reference these later, but certainly we know that older age at onset, as well as being a man, are poor prognostic factors. We also know that if we look at clinical factors, high relapse rate, right? Also, if someone has a spinal cord onset, which this patient did, that can be a poor prognostic factor. In terms of MRI, high number of T2 lesions, as well as the presence of spinal cord lesions, which are particularly the case with this patient. And then if we look at If we look at other biomarkers, again, this patient had oligoclonal bands in the CSF, and they also had high number of T2 lesions. So this patient had multiple poor prognostic factors, which may lead us to put them on what we would consider a more higher efficacy therapy from the start of disease. Now, another thing, this patient was an African-American woman, what we could see from the picture. And when we think about the face of MS, we're certainly learning more about MS in ethnic minority populations. For instance, there have been several studies over the past decade that have suggested that not only here in the US is there poor prognosis and poor outcomes in African-Americans and also in Hispanic patients, but that the risk for MS may be higher in the African-American population as well. So there was a study published from the Kaiser cohort that suggested that risk for MS was up to 47% higher in Black women. And so as we get more access to this type of data, it can help us to modify our treatment decisions. Also, when we look at clinical characteristics of MS in Black patients, we know that the disease progresses significantly faster. There are multiple studies looking at various MRI measures that suggest higher T2 lesion volumes. And there also are studies that suggest faster atrophy of the thalamus, which could be linked to cognitive impairment, as well as many studies that suggest higher EDSS. For instance, one suggested that Black patients may reach an EDSS of 6 up to 10 years earlier than their white counterparts. And some of this, in terms of higher disability, is also true of the Hispanic population. And I think one of the most impactful things, a study that was published 2 years ago by Dr. Liliana Amescua, was a study on mortality. And so we see not only this kind of narrative of more severe outcomes, but we also see potential effects on mortality rates. So this study looked at MS as the primary cause of mortality in this patient database. And so what we see is that very early on, between the ages of about 25 and roughly up to 45, that yellow line is the Black patients. And we can see that the mortality rate is higher in Black patients at earlier ages, which potentially suggests higher disability at younger ages. And so certainly this is an area that we need to concentrate and focus on, and to help understand why we see these outcomes in these populations. So the AAN has released guidelines that tell us a little bit about kind of the decision-making and when to start therapy. So certainly we want to look at things like patient preference. We want to look at route of administration, as well as tolerability and efficacy and safety, and before we make treatment decisions. But we really have moved to this thought process of shared decision-making, where we have a dialogue with the patients. And I consider treatment, at least with my patients, an ongoing conversation. At every visit, we're trying to decipher, is this still the right path? Do we need to switch courses? Are we still doing the right thing based on their disease activity, based on their tolerability, and based on if they're having any new issues or symptoms related to their MS? This is another graphic that just kind of illustrates some of the points that were made in the AAN guidelines. But certainly when we look at drug-related factors and patient-related factors, there are many things that we take into account when choosing a disease-modifying therapy. So we look at efficacy, we certainly look at dosing frequency and route of administration, and safety. We now think about sequencing considerations, because there are some medications, if they are cell depleters or potentially immunosuppressing, they may increase the risk for other side effects with some of our other medications. And then, of course, we look at patient-related factors such as prognosis and prognostic factors, comorbidities, risk tolerance, and of course, family planning. Another important thing to look at is not just kind of what are the things that we take into account when we are trying to choose a therapy, but also what are our ultimate goals. So certainly we have our traditional measures that we look at. We want to reduce relapses, we want to slow progression, and we want to reduce disease burden if at all possible. So we look at MRI and we look at clinical disease as kind of our measures to know if we're doing the right thing, if what we're doing is working, so to speak. But certainly as we have more disease modifying therapies come to the market, and we're able to treat MS more and more effectively, it hopefully will shift our thinking toward how can we actually have evolving measures like stopping relapses, stopping clinical progression, stopping MRI progression, and ultimately improving quality of life. And so hopefully these will be things we will be able to achieve in the future. So I think that it's pretty straightforward that early intervention is extremely important. And so this is a slide that just illustrates a little bit the importance of early intervention in terms of affecting our overall therapeutic response and delaying progression of disability. So we can see here the top line, which is, a significantly high level of disability is a natural course of disease. We certainly see that if we're able to intervene early, there is less disability kind of in the general trajectory. And also if we have later intervention, we still can do better than we would with the natural course of disease, but we don't quite hit the mark as what we would have if we started intervention and treatment as early as possible. So early diagnosis is key. And I think that our diagnostic criteria continues to reflect that so that we can accurately diagnose people as early as possible so that they can start treatment early.
So Mitzi, how do you decide whether to treat aggressively or not?
Absolutely. So I'm so glad you asked, and I would love to hear you and Dr. Cross's thoughts about this. So this has been kind of the hot debate. It's a little less hot than it was, 3 or 4 years ago, but still something that we think about. This thought of induction therapy versus escalation therapy. So I think that many of us who are MS specialists and also others in the field are looking at the possible benefits of treating people early with higher efficacy therapy. We certainly, I think most of us would agree that if someone has poor prognostic factors like the patient case that we discussed, that we would many of us would think of more of a higher efficacy therapy. But there are many that say that maybe all patients should be on high efficacy therapy from the beginning. And then we try to really slow down or stop disease and then possibly dial back to do another less efficacious therapy versus starting with efficacious, kind of going with our platforms and working our way up as people have more issues. I'd love to know you and Dr. Cross's thoughts about that, Dr. Radke.
Well, I have to say, I've become a bigger fan of induction therapy. I think as the agents are getting safer too, I think that's also an important consideration. Anne?
Absolutely.
Well, I really look at the patient and if they have high risk factors about them, then induction therapy is the way to go. But I try to ease them into that by pointing out to them that they do have high risk factors. If they're early and they don't have much on the MRI, don't have spinal cord lesions, then I may still be in the escalation category, depending on the patient. And of course, I work with the patient to decide what's best for them.
Absolutely. Absolutely. So I think at the end of the day, if you put 3 of us in a room, if you put 30 of us in a room, we probably get a wide variety of opinions. But I think the key is, again, that shared decision-making with the patient. And then certainly there are several clinical trials that are currently being conducted that will kind of put head-to-head the escalation technique versus the high induction. And we'll have some more data concerning that. And this was just one small study that looked at early intensive intervention versus escalation therapy. And it did suggest that those who started early intensive intervention did seem to have less disability accumulation. But again, we need more data to kind of have the science to say this is absolutely the way to go. And at the end of the day, again, if you've seen one person with MS, you've seen one person with MS, and each treatment plan is individualized. So if we look at the categories, and so this is what we were trying to get at with the initial question. So our immunomodulators will be considered more of our low to moderate efficacy therapies. So those are our injectable therapies and several of our oral therapies. The cell trafficking inhibition agents would be more of natalizumab and our S1P modulators, such as fingolimod, siponimod, and ozanimod. And then our cell depleting agents would be our alemtuzumab, most of our infusions, as well as cladribine, which is an oral therapy, and ofatumumab, which is an injectable therapy. And so again, when we look at the pros and cons of each of these approaches, certainly when we look at our immunomodulators, safety is a big pro, but certainly efficacy in some cases may be a con, as well as route of administration. And then with our cell trafficking agents, again, relatively safe, but certainly, relatively safe and well tolerated, but certainly some of the cons are some opportunistic infections that can occur, as well as because we don't have as much long-term data as we do with our injectables, and same with our cell depleting agents. Again, opportunistic infections, in some cases, secondary autoimmunity, and in some cases, the monitoring may be a bit cumbersome. But again, individualized decision where we sit down with our patients, look at their prognostic factors, and decide the best line of course of action for them. So when we think about matching a DMT to a patient to try to mitigate or decrease the likelihood of progression, this is just a graphic, and I think it's a great graphic that kind of illustrates some of the things that we take into account. Again, I'm not going to read everything here, but when we have a patient who has CIS or relapsing MS, if we're looking for someone, or if we're looking at someone who has poor prognostic factors, then we would go more toward our infusions and some of our oral agents. And some of the things that we take into consideration or that we need to check would be JC virus antibody status. We'd have to look at their adherence to treatments in the past. That would help us kind of decide if they need a once every 6 months, if they need a once a year treatment, et cetera. We also look at efficacy and family planning, right? Because we may need to adjust medications depending on their goals for family planning. And then when we look at those who have prognostic factors that are absent, and if we're looking at some of our injectable therapies or some of our other oral agents, we certainly want to consider if they have needle phobia, the monitoring that may or may not be involved, as well as family planning.
That's very interesting, Mitzi.
Yeah.
I think that now I'd like you to try to tell me about some of the clinical efficacy and safety data for some of the more recently approved treatments that the audience may be less familiar with.
Absolutely. So we'll spend the last few minutes talking about some of our newer treatments. So certainly one of them is cladribine, which we discussed a little bit. And we're just going to present just one slide about a little bit of the annualized relapse and MRI data for each one of these. So the Clarity trial had about 1,300 patients in it. And we can see on the graphic, the 2 doses of cladribine that were in this trial are listed here on the graphic, and but the 3.5 mg per kg was a dose that was approved. So the graph, the bar graph of the light green on the far end, that was not the approved dose. And the second numbers are for the dose that was not approved. So for the dose that was approved, there was about a 58% reduction in annualized relapse rate. 80% of patients were relapse-free in the treatment group versus those on placebo. And there was about an 86% reduction in gadolinium-enhancing lesions. There was some lymphopenia, and also of note in the Oracle trial, those with CIS did show delayed conversion to secondary to clinically definite MS, although the medication is not currently approved for CIS. If we look at ofatumumab, the Asclepios trials 1 and 2 looked at, had about roughly 900 patients, or a little over 900 in each of those. There was over 90% reduction of gadolinium-enhancing lesions in both of the trials for the treatment group, and this was a comparison trial, active comparator with teriflunomide. And so if we look at annualized relapse rate, reduction was over 50% for both trials. And also the safety and efficacy profile was very similar to teriflunomide, which was definitely a plus. Ozanimod, which is an S1P receptor modulator. Looking at the Sunbeam and Radiance trials, they had about roughly 1,300 patients in both of those. There was about a 63% reduction versus 53% reduction in gadolinium-enhancing lesions in the Ozanimod group. This was also an active comparator trial with interferon 1 beta A. Avonex. And so we could see that the Sunbeam trial did a little bit better than the Radiance trial. And also, if we look at annualized relapse rate, there was about a 48% versus 38% reduction for those on Ozanimod. And there, fortunately, were no significant cardiac adverse effects, lymphopenia, and macular edema in the patients who were in the treatment group. Diroxyfumarate was also approved. These were the Evolve MS1 and Evolve MS2 trials. Both of them were phase 3. One of them was open label, single arm, and the other was randomized double blind. And this was looking more at safety and tolerability, the Evolve MS1 trial. And so there were annualized relapse rate was similar to prior observations with DMF, but it was noted that there were lower GI adverse events with diroxyfumarate. And then finally, emerging therapies are BTK inhibitors. There are several of these that are on the horizon, many of them in phase 3 clinical trials, some of them actively recruiting, and some of them commencing. And certainly, we look forward to hearing more data about these newer therapies as well. So there is a great hope on the horizon. We have many new therapies that are being approved and many more, hopefully, options to offer to our patients in the future as well.
Thank you, Mitzi, for that excellent overview. Now we're going to turn to our final topic, which is on how we integrate biomarkers and imaging to assess disease activity and progression in patients with MS. Anne, can you walk us through how you use these techniques in the management of MS and what emergent technologies you think may influence how we practice in the future?
Absolutely, Mike. And before I get going, though, I want to mention that was like a wonderful talk by Dr. Williams. I really enjoyed that a lot. Great overview. Anyway, so I'm going to talk a little bit about biomarkers to begin with, both imaging and blood biomarkers. And here we're talking about the 2017 McDonald diagnostic criteria, which were changed a tiny bit from the 2010 McDonald criteria. And the crux of these, besides having clinical attacks, are MRI lesions. And for the 2017 diagnostic criteria, it requires 2 T2 weighted hyperintensities or lesions in 2 or more of the cardinal locations where you see MS lesions. And that's periventricular on the left there, juxtacortical or cortical, infratentorial, or short segment spinal cord lesions, such are seen on the right-hand side. And a couple of changes from the 2010 McDonald criteria include that for dissemination in space and time, we no longer make a distinction between symptomatic and asymptomatic lesions. And then interestingly, now we can also use cortical, so gray matter cortical lesions as one of these sites. But before we move from this slide, I wanted to mention a couple of things that sometimes have gotten us into trouble with the McDonald criteria. And one thing is that these criteria were determined based on people with very typical demyelinating syndromes. So they were validated in that type of person. They were also validated in people who were 55 years of age or less and were adults. And so we have to be careful if we apply them to people who don't fit that scenario. And for the typical demyelinating syndromes, the current criteria, the paper on that, goes through the different typical demyelinating syndromes, such as optic neuritis or internuclear ophthalmoplegia or partial transverse myelitis, those kinds of things that are typical, and distinguishes them. So I just wanted to comment that there have been several studies now that suggest there are a lot of misdiagnoses, and it may be partially because we're misinterpreting these MRIs sometimes and calling them demyelinating-like lesions when they aren't. Another thing that people have not maybe recognized as much, certainly I didn't really think about it as much until it was really pointed out that juxtacortical lesions have no intervening white matter between the lesion and the gray matter. And the same goes for periventricular, no intervening white matter. So that will help you distinguish from subcortical. So I'm really excited about some of the new biomarkers that are coming up in terms of imaging. And I think several of them are just right around the corner. So for example, we know from neuropathology that there are abnormalities in the underlying normal appearing white matter. And there are techniques now like magnetization transfer imaging and others that can actually measure and detect these abnormalities that you can't see on a standard MRI. In addition, there are new studies showing that slowly expanding lesions are associated with progressive MS in particular, but you can measure those and show that they're expanding over time. And then there are also lesions with a phase rim around the edge, which I'm going to show on the next slide, that are associated with progressive and worse disease as well. And then leptomeningeal infiltrate. So these are collections of immune cells in the leptomeninges that are associated with cortical lesions in particular, and also with progressive MS. And you can see them somewhat on a post-contrast 3D T2 weighted or FLAIR image. And so these may be a biomarker for ectopic lymphoid-like structures in the leptomeninges. We mentioned cortical lesions as they're now included in the McDonald criteria, and we're getting higher and higher resolution MRI so we can see them better. And then normal appearing gray matter has abnormalities as well. And of course, for years, we didn't even see these. And now we can at least measure gray matter atrophy over time, and whether at baseline these structures are lower than the norm. So here is a depiction of phase rims on an MRI. And the point to be made here, this is from a study from NIH, looking at progressive and non-progressive patients. And they found that patients who had more of these phase rim lesions, so there's a dark area around the center, around the lesion on the outside, if you had 4 or more of those, you had a greater chance of being progressive. And these are also associated with greater disability, both cognitive and physical.
So I understand that there's been a lot of buzz about neurofilament light chain as a potential biomarker in MS. Can you tell us more about that?
Sure, Mike. For years we know that neurofilaments are part of the structural components of axons or neurofibers. And when axons break, these neurofilaments are spilled out. And for years we could measure them in the spinal fluid, but nobody was doing lots of spinal taps to measure them. But recently we have really sensitive technologies. The one called a single molecule array or CMEO technology can actually measure neurofilament light chain in the blood. And the important thing is that spinal fluid and serum neurofilament light chain are very highly correlated. So now we have a means to look at the blood and measure components of axon injury. But important to know is that when you measure neurofilament light chain in the blood or elsewhere, it's not specific to MS. So in many other neurodegenerative diseases, you'll see lots of papers coming out, Alzheimer's disease, ALS, traumatic brain injury, strokes, other diseases where you'll see neurofilament light chain elevated in the spinal fluid and in the blood. So it can't be used as a specific marker for MS. The other thing to know about neurofilament light chain is that it goes up as we age. It goes up by 2.2% per year, even in healthy controls. So when you're looking at a level, you can't look at it out in isolation. You have to know how old the patient is and what the norms for that age would be. So what about neurofilament in patients with MS? I think the exciting thing is it seems to be predictive. Both spinal fluid neurofilament at baseline and also serum neurofilament data is coming out now is predictive of later disability, higher EDSS. So the higher the serum neurofilament is at the beginning, sort of the worst prognosis. And the other thing that's exciting about neurofilaments in the blood is that they seem to, and spinal fluid seem to correlate with treatment effects. So they might be usable to monitor the effects of drugs in individual patients. And so this could help us obviously practically in the clinic.
And do you think that NFL measurement could ever replace MRI, if perhaps just because of cost?
Well, I think it could for some, it's certainly not for diagnostics, but for monitoring patients, particularly serial monitoring, where doing MRIs on a yearly basis may be costly. Yes, I think it could. I think it could. I think it might not be right now, based on the data we have, it might not be wise to just look at one level. It might require serial levels, but I think there is that definite possibility.
Well, thanks for sharing those exciting developments. Now, can you take us through a patient case and show how you use imaging and biomarker data to help make treatment decisions when you manage patients with MS?
Sure. This case illustrates that pretty well. This is a 35-year-old right-handed woman who developed subacute weakness in her right hand. She also developed an electrical sensation when she flexed her neck down that went down her spine, so-called Lhermitte's sign. She, on MRI, and this is at baseline, had 5 supratentorial lesions and 1 posterior lesion at the level of C2 in her spinal cord, all of them looking like demyelinating lesions. And she got a spinal tap, which showed 9 spinal fluid restricted oligoclonal bands that weren't in the blood, an elevated IgG index, slightly high protein, which is seen a lot in MS, and 6 nucleated cells that weren't differentiated. So she seemed to have MS, and she works as a clerk, and her main complaints were fatigue and right hand clumsiness, which was intermittently worse and better. She was diagnosed with relapsing remitting MS, and she began interferon beta 1b given every other day subcutaneously, and was monitored annually according to the AAN guidelines. So she continued to take beta interferon for 2 years. She didn't like it very much, but she took it adherently. She didn't like it because she got flu-like symptoms, but she didn't have any obvious clinical worsening or relapses. And she was undergoing her yearly surveillance MRIs as suggested by the AAN. And she had one that showed a single gadolinium enhancing juxtacortical lesion, which was not symptomatic. And this was in addition to, of course, her already known brain and spinal cord lesions, which were unchanged. And she denied missing any doses of her beta interferon therapy. And there's the lesion. It's a enhancing juxtacortical lesion, pretty clearly typical of demyelination. So let's get the audience involved and ask a question here.
So Ann, let me ask you, if you were monitoring NFL and you saw a significant increase, would this sort of be the same? You could ask the same question.
We don't have data on that yet, Mike. That's a study that you need to do, or somebody needs to do with lots of patients. I don't think we have the answer to that yet. You don't want to keep her on interferon beta 1b. So, and the reason is she has this new asymptomatic gadolinium enhancing lesion, but studies show that patients who have that and they're taking beta interferon therapy, they don't do as well down the road. For example, and several studies have shown this, but a follow-up study of the pivotal beta interferon 1A study found that people who had new enhancing lesions, that predicted disability worsening with an odds ratio of 9, almost 9. So, that would not be a good thing to do for Lorene. So here are the AAN guidelines, again, mentioned previously by Dr. Williams. So amongst their recommendations of this very astute group of investigators in the MS world were to monitor MRI disease activity from the clinical onset of disease to detect the accumulation of new lesions to inform treatment decisions in the future. And they did, in some studies, a yearly monitoring has been suggested, although in some cases that may not be frequent enough. In others, it may be too frequent. But early on in the disease, and especially after changing disease-modifying therapies, it's probably prudent to monitor with MRI at least yearly. And then annually see the patient and follow up with them no less than once a year, and look for not only clinical worsening, but also medication-specific risks, to monitor for those with either blood work or other measures. And of course, to monitor for medication adherence, because that has been a big problem in the past in our patient populations, and for adverse events and tolerability to the drug. And Of course, as Dr. Williams mentioned several times, a lot of our patients are young women and they're of childbearing potential, and they may make a decision to have a child and not think that they should tell us. So we should definitely make sure that they know they should do that and take that into account when we prescribe medications. And then if a switch is needed in a disease-modifying therapy, discuss it with the patient and try to decide on the best next step. So here's another case, and it's going to illustrate some different things. So this is Jacob. He's a 46-year-old attorney. He's got, in the past 3 weeks, a progressive new cerebellar type tremor and incoordination, and this is new. And when he came into for that first interview, in retrospect, he had had pins and needles in both legs that lasted about 3 days, about a year earlier. And at the time, he, thought about seeing a doctor, but then it reminded him of just what happens when you cross your legs too long. And although he did think it lasted a little too long, but it went away. And then also upon sort of deep interview, he admitted to urinary frequency and urgency that other guys his age didn't seem to have. So here's what his MRI looked like. So this is diagnostic, the diagnostic MRI at the beginning. He had multiple lesions. He had infratentorial seen in the upper left, and he had lesions that are periventricular. And in addition, he had that left cortical or juxtacortical lesion that was enhancing. The bottom panel is post-contrast. So you can see that it's enhancing. And he also had another ring enhancing lesion that was periventricular in the left hemisphere. So, the diagnosis of relapsing remitting MS was made. And he came in for another visit to discuss disease-modifying therapies. And we learned that Jacob was very concerned about his potential exposure to the SARS-CoV-2 virus, and also about the effects of the disease-modifying therapies on his ability to fight that and so forth. And he had a lot of good questions, which among them were, will immunosuppressive drugs or any of the disease-modifying therapies make him more susceptible to COVID-19 complications? He also asked, does having MS itself make you more susceptible to COVID-19? He wanted to know, if he does get COVID-19, is it likely to provoke another MS relapse? And he wanted to know, thinking ahead, what the effects of the different disease-modifying therapies he was contemplating would have on his response to SARS-CoV-2 vaccines.
I think a lot of our patients are concerned about the risks of COVID-19. Can you tell us about any real-world data that has been accumulated so far regarding the interactions between MS and COVID-19?
Yes, we do have some now, and they're mainly from registry data. There are registries all around the world at this point. In North America, we have the COVID-MS voluntary registry, where information is put in by a clinician, and they're picking up data on what things are associated with bad outcomes, basically, or good outcomes. And it was started very early on April 1st, and it happens to be housed at Washington University, where I am, but we have entries from all over the place, and it's run by Dr. Amber Salter. So at this point, we have over 1,800 confirmed MS cases in this database. It also has a few neuromyelitis optica cases, and most of those are laboratory confirmed. Early on, when we didn't have easy access to testing, was when a lot of the non-laboratory confirmed cases came in. The vast majority of people recovered or are recovering, and we have had so far around 3.2% death. One issue with this registry, and really any registry, is that there's no good denominator. So when I say 3.2% death, that's amongst people who were put in, and it actually could be high or low depending on what the true denominator is. Interestingly, 3.6% of the people in the registry had no symptoms and have positive tests. So some of the findings from that include that the people who ended up dying were older and tended to be male, but no good information on most of our FDA-approved medications for MS, disease-modifying therapies, was no solid information in terms of making patients more at risk for death was found, as you can see in these figures. In fact, the disease-modifying therapy that was associated with death was having no disease-modifying therapy. But the other things that were associated were, or that seem to be coming out of these registries, is that MS itself doesn't seem to convey a worse prognosis. If you have MS and you're walking, you tend to do as well as the general population. However, if you have MS and you have ambulatory problems, then that group had a higher risk of being hospitalized. And the other risk factors that we're all familiar with now of older age, male gender, cardiovascular disease, obesity, diabetes, those were all associated with the worst outcome, meaning hospitalization or requiring respiratory support or dying.
And do you know if this registry is collecting vitamin D data?
I do not believe it is, Mike. I put a number of patients in myself, and I had not seen that as a question, no.
Because one of the things that's interesting to me, and I don't know if you saw this data, is that low vitamin D level in all comers, not just MS patients, portends with a much worse prognosis. And so one of the things that I think is worth telling our patients, if you aren't doing it already, is to take vitamin D.
Yes.
Now that we're starting to give vaccines to patients, I bet they're asking you about whether they should get vaccinated. What do you tell them?
Well, I generally speaking tell everyone who has, unless they've had some significant reaction to a prior vaccination, that they should, because for the most part, the risk of getting COVID-19 far outweigh the risk of having an anaphylactic reaction. In fact, from what I can see from the data out there, these mRNA vaccines that are available now in the US, the Pfizer and the Moderna, are very effective at reducing COVID-19 symptoms and such. And in addition, they seem to be pretty safe. They are associated with anaphylactic reactions in about 1 in, I believe, 100,000 or so people who receive them. And that's why it's recommended that when you have these vaccines, you stay in that medical area for about 15 to 30 minutes and have them monitor you. So that's the way it seems to be playing out. But these anaphylactic reactions so far have been reversible with appropriate treatment. So I do advise it. So this slide is from a paper, actually, that a review paper that my senior fellow right now, John Ciotti, wrote with me and one of the residents at the beginning of the summer. And what we were looking at, what he was looking at, is how people taking different disease-modifying therapies responded to different vaccinations in multiple different papers through the years. And so this is getting at Jacob, the attorney's question about how the disease-modifying therapy he might choose would affect his response to a vaccine. And he's, of course, thinking about COVID-19 vaccine. None of these studies, of course, have been done with the mRNA vaccines for COVID-19, and most of them were with like the seasonal influenza vaccines. But what was found is that multiple studies have been done with beta interferons. It doesn't appear that they have any effect on response. You should expect a normal response. For glutamer, teriflunomide, dimethyl fumarate, and probably the other fumarates as well. Most of the studies showed a good response, nearly normal. So one would expect that these folks would have a reasonable response to mRNA vaccine or vaccine for COVID-19. With natalizumab, the responses were tended to be reduced compared to interferon beta and glutamer in several studies. And for the sphingosine 1-phosphate receptor modulators, the responses when people are taking them on a daily basis were reduced in the studies. There still can be some response, though. It's not like there's zero response to any of these. There was an interesting study with siponimod, which has a very short half-life, where the investigators had one arm of the study where they stopped the siponimod a week or so ahead of the single vaccine, and then kept the patients off that, and then gave them time to respond to the vaccine, and then put them back on siponimod, and they had a very good response to the vaccine. However, we are dealing now with COVID-19 vaccines that have 2 shots and a period of time between them. So I'm not sure exactly how one would arrange this to go with that scenario. And then the cell depleting agents, particularly the B cell depleting agents, I mean, we would expect a significantly reduced, at least humoral vaccine response to COVID vaccines based on what's in the literature for the B cell depleting agents. And there's a very good study with ocrelizumab published. And then with alemtuzumab, the study that's out there suggested that if you wait a while after alemtuzumab, that 6 months or so, that you will get a near normal response, but you shouldn't give a vaccine immediately after alemtuzumab. And probably it'd be something like that for cladribine, but we don't have a study yet to refer to.
Well, we've covered a lot today, so let me wrap up by reviewing the SMART goals. I think first you should consider prognostic factors and drug-specific factors to determine your therapeutic approach to patients with MS. You want to partner with patients to discuss their treatment goals and how to optimize their outcomes. And I think it's important that you try to integrate the recent clinical data into your treatment management of patients with MS. Now we're going to try to answer some of your questions. So one of the questions here is, what does the term immune reconstitution therapy mean? Is it for all B cell depleting therapies or all induction therapies? I guess I'll give that one to you, Anne.
Thanks, Mike. I think it actually belongs to you more than me. But I would say I would not call a B cell depleting therapy an immune reconstitution therapy because it's just one specific subset of the immune system, and we don't have enough data yet. I think what they mean by that is that you blow out the immune system and then allow a new sort of naive immune system to come back. And for me, that's more of the alemtuzumab type treatment or hematopoietic stem cell transplant type therapies. But what do you think?
Yeah, I mean, I would say that too. One of the things I always like to say, it's B cell depleting therapies. You don't really get rid of all B cells completely. And I think that's one of the things that we've seen with, certainly with vaccines for flu, like you were pointing out earlier. Mitzi, I have a question for you. Do you differentiate between the different S1P receptor modulators?
Yeah, so great question. I think that certainly there are some nuances depending on the patient, especially depending on comorbidities. So fingolimod, certainly we have to do first dose observation with, which can be in some cases cumbersome, as well as, a visual ophthalmologic exam. With siponimod, we don't necessarily have to do the monitoring with everyone, but certainly still may have to do the ophthalmologic exam. And there's also genetic tests that has to be done. And then with the newest one, ozanimod, you may not have to do the ophthalmologic exam or the first dose observation, but there are some potential interactions with other therapies. So again, I think, it's very individualized based on the person that you're seeing, their comorbidities, which one may be the right option for which patient. So the short answer is yes, I do slightly. And then of course, there's always the one that the insurance will approve. So then there's that.
I have a quick question for Ann. How is serum NFL affected by renal function?
I don't know the answer to that, Mike, but I don't think I should even venture a guess since I don't know the answer. I don't know how it's cleared.
Okay. I'm not sure of that one either, to be honest. I have a question, an interesting question here. Do any of the newer drugs like cladribine, ofatumumab, or ozanimab, are they compatible with psychopharmacologic drugs and with the treatment of depression in patients with MS?
So the only one that I can think of, and you all can chime in as well, that would potentially have an interaction with psychopharmacologic drugs would be ozanimod. Again, there is some extension phase data that was published at ECTRIMS, and there were patients who were on SSRIs who did not have any issues or did not have hypertensive crisis from the medication, but certainly that is a concern that's listed in the labeling. And I don't know of any others that have that same concern. Do you all know of any?
So let me ask you both. Would you treat a CIS patient with an induction agent if they had poor prognostic factors?
Well, I could go the safe route and tell you that the FDA has only approved a limited number of our disease-modifying therapies for CIS, meaning a single clinical attack. So if they were at high risk, I'd probably choose something like siponimod, which is approved for CIS now. So choose that one.
Yeah. So if it were someone, so if, again, every case is individual. If I had, for instance, someone with, let's say, multifocal onset, right? So they had motor and visual things happening at the same time and very significant disease on MRI, which is not common, with just CIS, then that would be a person I would consider potentially for an induction therapy. But I think that also one of the S1P modulators would be very reasonable if literally they only had one attack.
All right, this is a tough one, but I'm going to give it to you, Anne, because I know you trained partially at GW. Can you comment on the use of cannabis in patients with MS?
Boy, Mike.
It's legal in DC.
And gets all the good ones. Yeah, it's not legal in Georgia. That's my disclaimer.
Yeah, it actually is legal here and in Illinois, where a lot of our patients come from. I have taken the stance that the legal cannabis that you can get is probably far better than things that you buy on the street, where you don't know, the amounts of different things within what you're buying. I have advised my patients that if they want to get it, and we're actually not allowed to prescribe it at my institution, so that takes me off the hook, but I don't stop them. I tell them they should try it, but they should get it from a reputable, pharmacy, not on the street corner.
Have you actually used it? Do you think it affects cognition in an MS patient?
So I think certain parts of the marijuana do. There are, and I'm not any expert on this, so I shouldn't, say too much. But just smoking, weed that you would buy on the street definitely can affect cognition, and I believe there are studies even showing that there are more car accidents. So that's another reason why you want to buy something where you know what the ingredients are.
All right, here's a biomarker question, but I feel it's a softball. Do you see positive aquaporin 4 antibody with MS, with or without the VIX? And does this antibody increase the likelihood or extent of lesional edema?
It's a field goal. And no, aquaporin 4 antibody is very specific for NMO. And so neuromyelitis optica, or NMO, which is anti-aquaporin 4 antibody positive, is a specific disease that is different from multiple sclerosis, and they are treated differently. And actually, NMO has 3 FDA-approved medications now for it that are different from MS. So yeah, I mean, new therapies that look good. They're all monoclonal antibodies, so we want to differentiate it, but it's a different disease.
Dr. Williams, can you give more info on the higher incidence of MS in Blacks and Latinos?
Yeah, absolutely. So the incidence potentially is higher in Blacks, not Latinos. So the incidence is actually lower in Hispanic and Latino populations. So there are a couple of studies. There was a VA study that was published in 2012 that showed a higher incidence in Black men and women. And then there was the Kaiser study in 2013 that showed a higher incidence in Black patients, but that was primarily driven by the higher incidence in women, which was roughly about 47% higher from that study. And so, again, we don't really understand why we see the higher incidence. We also don't really understand why we see the worst outcomes and the kind of interaction of socioeconomic factors and social determinants of health and biology. We still have a lot that we need to figure out.
All right. And here's another one that's kind of interesting. There apparently was a case of transverse myelitis after one of the COVID mRNA vaccines. You think that these vaccines trigger enough inflammation to make MS activity worse?
So I think that was after the AstraZeneca, which is a chimp adenovirus vectored mRNA. It's non-replicating, so the adenovirus doesn't replicate. And I think that the last I saw, there were 4 cases of transverse myelitis associated with that study. One case was in the placebo arm. And then one case was somebody who either, I think, already had MS, but that's still worrisome to us. And then a couple of cases. So obviously that particular vaccine has been approved in the UK, and they did not think that was enough of a increase. But I think I personally am going to advise my patients to try to steer away from that one if it becomes an option to them. And I don't know, I'd like to get more information on those transverse myelitis cases.
All right, Mitzi, how about for a patient with secondary progressive MS doing well on, I guess, pulse solumedrol, are there any other options realistically for this patient?
So it depends on whether their secondary progressive is active or non-active. So we have this new designation from the FDA of active secondary progressive MS, and many of our medications are approved for that now. So the S1P inhibitors, as well as some of our other therapies. So I am generally not a fan of prolonged pulse solumedrol just because of long-term side effects. Such as osteoporosis, also, elevated glucose, some people develop diabetes, etc. So I'm assuming if that person is active enough where they need pulse solumedrol, they may be a candidate for a DMT. So the short answer is yes, there are DMTs approved for active secondary progressive MS.
So I'm going to take this next one, which says, what about the use of turmeric in decreasing inflammation in the brain, encapsulated in phospholipids? Now, as many of you probably know, turmeric does have anti-inflammatory activity. We actually, if you look, I think it's published, it's online in JCI Insight. We just published a paper on LLL12B, which is an oral agent that we designed to mimic turmeric in its ability to inhibit STAT3. And so this gets back, if you think about the pathogenesis that we talked about earlier, that STAT3 is one of the important transcription factors. And instead of trying to manipulate it by doing something at the cellular level, which is what we do with most of our treatments now, this is actually trying to deal with it at the transcriptional level. So the question is it better to do it with the agent like turmeric itself? And how do you give it? And how has that been tested versus a molecule that's been tested extensively? And I guess that's really the $1 million question. So here somebody asked, do you think it could be the lower vitamin D level in Black patients that could be responsible for their increased disease activity? I guess that's for you, Mitzi.
Yeah, so that's a possibility, right? But there's all this controversy about vitamin D. There was even a study published that said maybe we're not looking at the correct vitamin D marker in African American patients. But certainly there are many people with low vitamin D. that don't have the same severe outcomes. So I think it may be playing a part, but it certainly is not the whole story.
So what do you think about a cell trafficking agent, inhibiting agent like natalizumab for highly active disease? I guess
so many people, oh yeah, so many people do great on cell trafficking agents such as natalizumab. Obviously, we need to keep track of JC virus antibody levels and titers and check those periodically to determine risk for PML. But yeah, so absolutely, it's a great choice for highly active disease.
And can CBD have an anti-inflammatory effect and protect the myelin sheath?
I have no idea, Mike. I really, do you know anything on the literature on that?
I consulted for a company for a drug called dexanabinol that appeared to have neuroprotective effects and supposedly didn't have the psychotropic effects of cannabis. But I don't know specifically for CBD oil. Now, Mitzi, I'm going to ask you, are you encouraging patients to get both flu and COVID vaccines?
Yes. Not at the same time, but yes, I encourage my patients on a regular basis to get the flu vaccine, and I am currently encouraging my patients to get the COVID vaccine once it's available to them. I got my first half, and so I'm waiting on my second half.
I was going to say, I hate the self-promotion, but one of them says, excellent program and love the videos. Do you think natalizumab would affect vaccine efficacy from a biologic viewpoint? Anne?
That's interesting. I mean, natalizumab blocks VLA4, and that molecule is involved in trafficking not just into the central nervous system, but into other organs too. So one could imagine that it might impair trafficking into certain organs where one, even lymphoid organs. But I don't know of that data. But I can tell you that from the influenza studies that I mentioned earlier, it did seem to have a negative effect on vaccine response. And
yeah, I mean, and you're exactly right about that, not just going into the CNS. As a matter of fact, when I was involved in the natalizumab studies, we were actually blinded as a treating physician from the laboratory data because the lymphocyte count goes up when you're on natalizumab because you're not trafficking it both into the brain and the lymphoid tissue as well as you would normally do it.
So
now, this is for both. I can tell you, zinc with ivermectin has been recommended for early COVID treatment by a number of pulmonary critical care providers. Ivermectin can have hypersensitivity reactions. Would MS have any problems with ivermectin that any of you are aware of?
Well, zinc could cause a problem because it inhibits absorption of copper. Not that it would make MS per se worse, but it has the potential for causing a spinal cord problem due to reduced copper. So you have to be careful giving zinc or too much zinc. I've heard a little bit of this ivermectin story listening to podcasts, but I don't think there's any strong data to use it yet in people, although I do understand some people are using it off-label.
Right, and I suspect like if you had the treatment like the IV antibodies for COVID, that wouldn't have any adverse effect on your MS.
Mm-hmm. May I ask a question? Have either of you, Mike and Mitzi, used bamlanivimab or the other neutralizing antibodies to the SARS-CoV-2 virus, and what have you seen?
So I have not. I have not. Yeah.
Okay. I put my second patient to got it this morning, and I haven't talked to her yet. But the first one did great, and the next day she felt like wasn't sick at all. So
yeah. Yeah. Now I did have a family member, not a patient, but I did have a family member that received remdesivir, and it was a very quick turnaround, and they were very, very sick. They were hospitalized, and once they got remdesivir, they literally turned around within like 24 hours. So I have not seen it in my patients.
All right. I guess the last thing that I would ask, it talks about the induction therapies. And I guess the person says, are they higher risk? And I guess I would have said yes. But what would you say, Mitzi?
So theoretically, yes, right? So I mean, of course, every risk is a potential risk, right? So, with all of there are some that are very, common, but are more severe adverse effects such as PMLs, such as, concern for malignancy does not occur in a majority of our patients who take these therapies. So theoretically, yes, they are higher risk because we have to talk about things like malignancy and opportunistic infections that we don't necessarily have to discuss with some of our platform therapies. But again, they also have more potential benefits because of higher efficacy. So yes and no. I will be equivocal.
I guess the
yes
one thing
no.
I would say, though, and I've been involved now with the hematopoietic stem cell transplants for, gosh, probably when I was at WashU, I first started talking to John DiPercio.
Yeah.
Mm-hmm.
And clearly, we've gotten so much better in how we transplant patients.
Right.
And we've gotten so much better in selecting that before, when there was, and I think rightly so, people were very concerned about the risk of mortality for that. And I think that's been dramatic to the point where I believe it's something like in the last 400 patients that have received autologous hematopoietic stem cell transplant for MS, there's not been a death. So, and that's talking about the whole world, not just the United States. To receive CME or continuing education credit for today's program, click on the Evaluations tab to complete the post-test and print your certificate. As a reminder, if you would like to claim this activity as a CME for MIPS improvement activity, follow the steps described on this slide. Again, thank you, Mitzi and Ann. I think this has been a great discussion, and thank you, our audience, for all the great questions you sent in. We hope you'll be able to use this information that we have shared and change the way that you provide care to your patients with MS in your clinical practice. If any of your colleagues missed today's program, it will be archived at cmeoutfitters.com. Also, please check out the Multiple Sclerosis Hub that contains resources we've selected for you and your patients, including the great animations we saw today. And I should tell you that when you go on that site, you're going to be able to spin it yourself, stop and go, zoom in. I mean, it really is a fantastic tool to help explain what's going on in the pathogenesis of MS and to use that to educate your patients. Thank you again for participating, and thank you for providing the best care for your patients.